Good evening, friends. Welcome to our Tuesday academic session from the Department of Critical Care Medicine, Yashoda Hospitals, and other specialty departments. Like today, we have hepatology. So as like other topics, we try to bring some interesting new debates, new areas of advancement and research. Today, we have an interesting topic like what kind of extracorporeal support we can offer when we get across or come across a patients with acute liver failure. Either it is a toxin or a virus, or sometimes a chronic liver failure that is acutely decompensated. There were many supporting devices came across in the last few decades, but many of them have their own pros and cons, risks and benefits, and their utility has been always under the scanner. But of late, we have come across the high volume plasma exchange, and then there is a normal volume plasma exchange being a phenomenon which has shown some promising results, and that also has gone through the ups and beats. So for that, to bring, we have Dr. Vishnu, Vardhan Raju, who is a senior consultant in the Department of Critical Care Medicine. He carries a rich experience in both critical care and also the transplant anesthesiology in the liver, and he's been a part of the transplant critical care medicine during his tenure in earlier institution. And we are honored and privileged to have Dr. Dharmesh Kapoor. Sir, can you be on camera, sir?
Yeah, good evening.
So
good evening to everyone.
Honor and privilege to have Dr. Dharmesh Kapoor, who is our head of the hepatology and the transplant medicine in the livers. And he's a seasoned speaker, academician, and he has been one of the clinicians who in this part of the world look for the academics and all. And it's our honor to be with you, sir, and a part of this session. Thank you for joining us, sir.
My pleasure.
So I'm now over to Vishnu to actually take us through the initial, the overviews of extracorporeal therapies which we offer in the acute liver failure. Over to you, Vishnu.
Good evening, everyone. So, thank you, sir, for introducing me. So, we would like to talk about extracorporeal liver support devices that have been used in the last 30 years. So, before going to that, I will slightly say about the history and all those things before going to the devices. So as we all know, liver is a complex organ with various vital functions in synthesis, detoxification, and metabolism. So if the liver fails, it constitutes a life-threatening condition. So liver failure can either can occur without preceding liver disease or as an acute decompensation of liver-related illnesses. So coming to the pathophysiology of acute liver failure, how it causes organ dysfunction, all those things. So when there is a liver failure, there will be decreased synthesis and decreased metabolism and decreased detoxification. So which in turn results in accumulation of the vasoactive toxins. So some of them are albumin bound and some of them are water soluble toxins. So which in turn, these toxins activates the CIRS response. So which in turn releases many mediators like interleukin 6, tumor necrosis alpha, and interleukin 8 and many other cytokinins, which in turn causes multi-organ failure affecting almost all the organs like cerebral dysfunction, circulatory dysfunction, renal dysfunction, which in turn causes so the further liver failure and leading to the death. So in these patients, unless the liver has to be generated, or the patient won't be surviving in this. So either he has to, the liver is able to regenerate, or he has to be listed in the high urgency transplant. So because high urgency transplant, it is very difficult to get the donor organ, and we don't have, we have to support him till he recovers or till the transplant is done. So unlike renal failure, the artificial support systems that were not widely used in liver failure. So because most of the hepatic toxins that are albumin bound, which is very difficult to remove by the conventional dialysis. So only in the recent advances have been made. So these devices have been made in the last 30 years to remove the hepatic toxins. So extracorporeal liver assist devices has been developed to bridge the patient to transplant or temporarily support the failing organ until it is being able to be regenerated. The same thing. So when there is a liver failure, so either due to acute liver failure or acute and chronic liver failure, these extracorporeal liver support devices, either they bridge to the transplant or temporary stabilization till the liver recovers. So these are the albumin toxins that are removed. So mostly aromatic amino acids, bile acids, bilirubin, so copper, so middle and short chain fatty acids, phenols, and all those things. So indications for considering artificial liver support devices, there are mostly 4-5 indications where we can use these systems, like in acute liver failure that can be caused by toxins or hepatitis A and B viruses, or in some acute alcohol hepatitis decompensation, or in patients where acute exacerbation, acute on chronic liver diseases, or in patients with HRS1 where there is sudden deterioration of liver function, so with acute renal failure, or in a patients with chronic liver disease with HRS type 2, so till the liver transplant is feasible, or following liver transplant, so they may be indicated in the primary non-function or delayed graft function. So coming to the types of artificial liver support systems, they are broadly classified into artificial, which are non-cell based, and bioartificial, which are cell based. So there are multiple devices, out of which so non-cell based are like molecular absorbance recirculating system. So it's called as MAS, or fractionated plasma separation and absorption, Prometheus, single pass dialysis, albumin dialysis, or therapeutic plasma exchange. These are the few, so which I'm going to discuss today. And bioartificial, or it's a cell based, so in which I'm going to talk about ALAT, bioartificial liver or hepatitis, and MELS, and academic medical center valve. So key functions, like in artificial non-cell based, they only remove the toxins, so they don't have any synthetic functions as there are no liver cells in it. In bioartificial, as they have liver cells in the filters, so they perform not only synthetic but also metabolic functions from the hepatocyte modules along with the toxin removal, which improve the survival rate or include bridging to the liver transplant. So coming to, sir.
Just can you be in the straight in the there?
Sorry, sir.
And your chair is moving, so your arm is getting the, and tilt it little. Half of your head is not coming.
Okay.
Right. Perfect. Go ahead.
So artificial liver suppose the pros and cons, like the pros are like it is relatively easy to use. It ameliorates pathophysiological features, and it is more advanced clinical development. Cons, like it lacks synthetic functions, inspecificity in removal of some compounds, and the cost. Bioartificial liver support devices, the pros are not only removing toxins, it provides like synthetic functions as well. The cons are, so to get the cell source, and we need to keep the bioactive mass critical, and we need a complex technology and a potential xenotransmissions, and huge cost is involved in producing these filters. The same thing, so I'll skip this slide. So we'll first discuss about molecular absorbent recirculating system. It's called MAS. So it is available in clinical use since 1993. So it is based on principles of protein binding affinity of the dialysate albumin and the solute movement across the concentration gradient. So it is a combination of conventional dialysis against an albumin dialysate is utilized, followed by traditional procedure to remove the toxin from the dialysate. It is composed of blood circuit, albumin circuit, and a classical renal circuit. So once the blood is passed through the albumin impregnated high flux dialysis membrane, so it removes both water soluble and albumin toxins. So removal of toxins takes place through a diffusion, which depends upon the free toxin levels. So the albumin dialysis is then recycled, eliminating the need for continuous infusion of albumin. So after that, it is passed through a normal dialysis where the water soluble toxins are removed. It not only removes, it also removes cytokinins and modulate the inflammatory response involved in liver failure. So which helps in the regeneration of the liver and prevent further injury of the liver. The same thing, principles. It uses polyaryl ether sulfate membrane. So it selectively removes solutes up to 50 kilodaltons. It has high absorptive capacity. So high availability of toxin binding sites in albumin dialysate. So presence of free toxins. So free floating toxins in the serum. So this is the mission which it looks like. So the most of the substances that are removed during MARS are albumin substance like benzodiazepine, bilirubin, both conjugated and unconjugated. So nitric oxide and also water soluble substances like ammonia, interleukin 6, tryptophan, tumor necrosis factor alpha, and urea. So the beneficial effects of MARS is like it decreases mortality in type 1 HRS. So it decreases serum bilirubin. So it improves in marked cardiovascular hemodynamics and subsequent renal functions. So improve in hepatic encephalopathy and decrease in intracranial pressures. So advantages of MARS, like it is effective and selective removal of water soluble and protein bound toxins. Not only removing the toxins, it is used in the management of fluid, electron, and acid base balances. So control of sugar and lactate levels, and it is a highly biocompatible membrane and minimal staff handling and cost effective. It is compatible with the regular CRRT Prisma monitor. Disadvantages is there are several questions that has been raised about the stability of the binding proteins of the albumin after passing the absorber column. There are many studies. So with clinical endpoints of acute liver failure using MARS. So there are out of which Saliba et al. So in 2013 is the only controlled randomized multi-center trial where they studied MARS along with the standard medical therapy versus standard medical therapy. So they have studied about 1 or 2 patients in them. So there was no significant improvement in 6 months transplant free or 1 year survivals. So in all the other studies which were done, they showed no mortality benefits, but there was some neurological and hemodynamical improvements in these patients after using the MARS. So, and the studies with clinical endpoints for acute and chronic liver failure using MARS. So there's a Banaras et al. Study which was done in 2013. It's a controlled randomized multi-centric trial. They compared with MARS along with standard medical therapy versus standard medical therapy. So in this, they studied about 156 patients. They also didn't show any 28-day and 90-day transplant-free survivals. So coming to Prometheus, which is a fractionated plasma separation and absorption. It was first described by Flakenhagen. So patients' blood first it is passed through the Abu flow filter. So the membrane porous capacity is around 250 kilodaltons. Here the plasma is first filtered and passes into the secondary circuit where the albumin toxins are removed, and this albumin is reactivated and returned to circulation using a Promet 1 and Promet 2 filters. There are neutral resin absorber and ion exchange column. So after that, the blood then re-enters the conventional high flux hemodialysis circuit where it is treated to remove the water soluble toxins before being returned to the patient. So here the same, the blood from the patient enters into the Abu flow filter. So where the first the albumin bound toxins are removed, then the blood flows through the normal dialysis circuit where the water soluble toxins are removed. So initial studies demonstrated performance better than the MARS, but there is a significant decrease in serum ammonia, bilirubin, aspartate, aminotransferase and alanine aminotransferase, urea and creatinine. So in the studies by Rifa et al., they demonstrated a decrease in almost all 26 amino acid measures in the liver failure, and Risk et al. Demonstrated significant decrease in ICP in groups treated with Prometheus. In Rosen et al. Demonstrated significant decrease in most cytokinins and inflammatory markers concentration with Prometheus. So there was no clinical improvement except for improvement of encephalopathy demonstrated in few studies, and hepatic growth factor concentration increased significantly, could have favored hepatic regeneration. So Deathloff et al. Showed improvement in MAP with Mars and Prometheus and conventional therapy. So studies with the clinical endpoints using Prometheus. So there was a Kriban et al. Study in 2012, where the randomized control study multicenter compared Prometheus with standard medical therapy versus standard medical therapy. So they studied around 145 patients in acute and chronic liver failure. So they found no improvement in 28-day and 90-day survival, except in a subgroup with MEL greater than 30. So now coming to single pass albumin dialysis. So it is the simplest artificial liver device described alternative mass in late 90s. So here the patient's blood dialyzed through a high flex hollow fiber hemodiafilter using the albumin containing dialysis around 2 to 4%. So after passing to the dialyzer is discarded and toxins removed from the system. The disadvantages being high amounts of albumin are consumed with SPAR. The same thing, high flex, where it is the dialysate membrane used with 2 to 4% albumin. So there were no significant differences in biochemical, hemodynamical, clinical values. So only few case reports were published in early years. There was no published studies that focused on demonstrating clinical benefits of SPAR versus standard medical therapy. Only randomized study was a crossover study comparing detoxification capacity and influence on clinical and paraclinical parameters, SPAR and Mars by Sponholz et al. So they showed that total plasma bilirubins are reduction. So other total bile acids and gamma GGT were non-significant. Creatinine urea levels were not significantly reduced by SPAR. Metabolic derangements such as increased lactate hypocalcemia was found with SPAR. So the effects of Mars and SPAR on clinical parameters were small and equivalent. So coming to therapeutic plasma exchange, so it dates back around 1960s, employed in cirrhotics to treat hepatic coma, where they did exchange transfusions. So historically, the TP in acute liver failure, so it was described in case series and cohort studies. So only recently there was a randomized control which was done by the Larson et al. In 2016. So TP in ALF requires extracorporeal removal of large compounds from the plasma. So and the plasma is replaced with the FFPs or albumin. The only therapeutic difference between the TP and extracorporeal assist device is like the TP removes larger molecular proteins, including antibiotics, immune complex, and lipoproteins. So and these all the cytokine SPAMs and DAMs can be removed with this. So till date there was no head-to-head clinical trials that has compared therapeutic plasma exchange with ACUTE. So when there is an acute liver failure and hepatic death, so which results in the production of damage associated molecular patterns and pathogen associated molecular patterns, which in turn causes macrophage activation. So all this results in increased inflammation and tissue damage. All this causes activation of pro-inflammatory macrophages, which in turn increases inflammatory mediators like monocyte activation and so which in turn produces interleukin 6, tumor necrosis factor alpha and interleukin 6. All these so cytokinins causes SIRS and multi-organ failure. This high volume plasma exchange. So this removes these damage associated membrane proteins and decreases the cytokinin level, which in turn causes decreased inflammation tissue damage and helps in hepatic regeneration and attenuate tissue destruction along with the improvement in the organ failures.
Vishnu, here I think we'll take Dr. Dharmesh's also opinion.
Right. So I think Dr. Vishnu, as you highlight in this particular slide, so this is basically a cartoon that is describing the sequence of events that are associated with liver damage. Now we should understand that this is a very simplified schema. So these particular things, they don't happen in any orderly manner. And while the tissue destruction is taking place, simultaneously the tissue regeneration also takes place. And why you get the syndrome of acute liver failure is because there is a loss of equilibrium between the tissue destruction or organ destruction and organ regeneration. Now, relevant to this particular subject that you are going to elaborate upon is the generation of these moieties which are potentially pro-inflammatory. The essence of using therapeutic plasma exchange is in patients who are predominantly pro-inflammatory. But we know that not just in liver failure, but in the intensive care, the patients don't announce the stage in which they are presenting to the critical care unit. So it all depends on when you are seeing this patient for the first time on your unit. For example, it has been well established, and this was established many decades ago, that there is a kind of a TH1, TH2 balance that is maintained, and the initial stage of injury is basically the systemic inflammatory response syndrome, where you actually succumb to the illness because of very marked inflammatory storm, and very rapidly you will go into a state of anti-inflammatory response, or the CARS phase, wherein you have a very poor representation of the antigens or the tissue antigens on the antigen presenting cells, and therefore you get predisposed to a multitude of infections. So this SARS-CARS conundrum is the key to utility of a modality like therapeutic plasma exchange. So probably this tool is useful when you are seeing these patients in the pro-inflammatory state, and might not be very useful or might be even detrimental if you are treating these patients later on in the course of the illness. So these are the things that we have to remember. So as you highlight in this cartoon, so there are upstream inflammatory moieties and there are downstream inflammatory moieties, and then there is just a spillover of the cytokines into the bloodstream. So things that you describe like TNF alpha, IL-6, IL-8, they have all been shown to be present in the plasma in very high levels in these patients. But remember that these are also the triggers for regeneration. So it is not as if to say that if you are able to mop up the TNF alpha through therapeutic plasma exchange, we don't know that for sure, whether that is only serving a useful function for the patient. So another thing is that you see something like high mobility group box 1. So these are later phases of inflammation. So all of these are removed by therapeutic plasma exchange, because over here you are able to remove very large molecules, and that probably is why this particular treatment has been more sought after in recent times compared to the other liver assist devices. So once your talk ends, we can actually just put into perspective the difference between the existing liver assist devices and TPE. So here I just want to make this point that because there are a lot of cytokines being released as well as pro-inflammatory markers, which we think might not produce a conducive environment for the liver to regenerate. So we think that removing this might be useful, but the final verdict on this is really not known.
Okay, please carry on this.
So this was a study which was done by Larson in 2016. So where they compared high volume plasma exchange in patients with acute liver failure. It is an open randomized control trial which was done in London, Denmark and Finland. So in this, they randomly assigned 182 patients with acute liver failure to receive either standard medical therapy or a standard medical therapy versus high volume plasma exchange for 3 days. So in this study, they used like a high volume plasma defined as like plasma replacement of 15% of ideal body weight or 8 to 10 liters of plasma per session. So they have done maximum of three sessions. The primary endpoint was liver transplant-free survival during hospital stay. And the second endpoint, they included survival after liver transplant with or without high volume plasma with intention to treat analysis. The proof of principle study evaluating the cause of high volume plasma, and the immune cell function was also undertaken. So the demographic pattern between the two groups are almost similar. So age, weight, height, and etiology. So they're almost similar in both the groups. So these are the changes in the clinical variables and bed gases in patients treated with plasma exchange versus control. So this is a busy slide. I would like to keep it as a simple slide. So in ALF patients who have received a high volume, so there was an improved mean arterial pressure and reduced in reduction in vasopressor requirement. There was requirement of few renal replacement and decrease in serum creatinine. So they showed to reduce ammonia levels and improve grades of hepatic encephalopathy, and the significant improvement in liver transplant-free survival. So with no difference in outcome between paracetamol and no paracetamol etiology in acute liver failure. In subgroup high volume therapeutic plasma exchange was shown to improve survival among patients not listed for transplant. And there is no significant survival benefit in patients who received high volume plasma exchange as bridge to liver transplant. So for the entire population they have studied, the overall hospital survival was around 58.7% for the patients treated with high volume plasma exchange, and it is 47.8% for the control group. So high volume plasma prior to transplant, as I said, did not improve survival compared with patients received standard medical therapy alone. So the incidences of severe adverse events were similar in both the groups. The SIDS and the SOFA scores fell in the treated group compared to the control group over the study period. So coming to the conclusion, treatment with high volume plasma improves outcomes in patients with acute liver failure by increasing liver transplant-free survival. This is attributed to attenuation of innate immune activation and amelioration of multi-organ failure. So there was one more study which was done in CMC Velu. So there's a preliminary experience of their the CMC Velu. So they used low volume plasma exchange and low dose steroids. They showed improved survival in patients with alcohol related acute and chronic liver failure and severe alcoholic hepatitis. So in alcohol related acute and chronic liver failure patients, they have a high short-term mortality. So it is unclear if steroids are beneficial or harmful, and it is uncertain if steroids should be used. So this plasma exchange improved survival in these patients. So they analyzed with low volume plex, 50% of the plasma exchange per session was done. It's around 1.5 liter, and low dose steroids around 20 mg was used to treat and tapered over 1 month. So the primary study outcome was 1 year survival in plex versus standard medical therapy group, and secondary outcome response to plex in patients with raised creatinine and HE and complications of plex. And they measured plasma 1 milligram fracture levels after plex and its level in plasma removed. So it is a retrospective study which was done in 2019. They actually screened almost 250 patients. So out of which, so they have taken 50 patients. They have included 50 patients in the study. So 21 patients who had plex and 29 patients had standard medical therapy. So the baseline characteristics are almost similar in both the groups. So coming to the results, like out of the 21 patients who are underwent plex and 29 patients underwent in the standard medical study. So all the 50 plex group received at least 3 plex sessions. So being 1 to 7 with a 1.5 liter of plasma exchange per session and oral prednisolone 20 milligram daily for 15 days and tapered to 10 milligram over next 15 days. So in this, the primary study outcome, survival over 1 year in these patients in the plex group. So the median survival for the plex group is around 15 days when compared to 11 days in standard medical therapy. So in-hospital mortality for plex was around 33%. In the standard medical therapy, it is around 45%. So the duration of hospital stay for plex groups for 3 months, non-survivors was 18 days, and for survivors is around 19 days. The overall survival estimate for plex versus SMT at 30 days was 66 versus 16.6. And at 16 days, it was 35% versus 11%. And at 6 months to 1 year, they showed it around 16.6% versus 11%. The same thing was depicted in the Kaplan-Meier curve. So Kaplan-Meier analysis showed better survival over 1 year in the PLEX group compared to the standard medical therapy group. The secondary outcomes, the study, there were response to PLEX in patients with renal dysfunction or hepatic encephalopathy presentation. So there were renal dysfunctions in 10 patients in the PLEX groups, which normalized in 6 patients after PLEX. In 9 PLEX patients had hepatic encephalopathy admission and 6 patients recovered from the hepatic encephalopathy. Those who didn't recover from these patients, they have died very early. So, and they measured serial plasma 1 millibrand factor levels in the PLEX group patients when they admitted and after finishing the PLEX and at the follow-up. So out of 11 patients treated, plasma 1 millibrand factor significantly decreased in 6 patients and they survived more than 3 months. So out of the 11 patients, compared to the survivors and the non-survivors, the survivors had a significant decrease in the 1 millibrand factor. The non-survivors, there was no significant decrease in the 1 millibrand factor levels. So limitations include a retrospective design, a small number of patients studied, and many patients lost follow-up. So they have not used ACLS specific disease severity score like partial ACL score to categorize study patients. So the study design does not permit us to discuss if steroids or PLEX or the combination improve the survival. So conclusion, compared to standard mortar therapy, low PLEX and low steroid improved survival over 1 year in alcoholic acute on chronic liver failure patient with severe alcoholic hepatitis. In patients with renal dysfunction, 60% showed improvement in renal function with PLEX. So studies with a large number of patients are needed to validate these results. So coming to the guidelines for this plasma exchange, in 2019, American Society for Apheresis has recommended high volume therapeutic plasma exchange as first line therapy for acute liver failure and fulminant Wilson disease. They also recommended that at least 3 cycles, procedures daily, and to consider performing daily treatment until liver transplant or liver recovery. In fulminant Wilson disease, a daily standard volume plasma exchange treatment until liver therapy or liver recovery is recommended. In 2016, European Association for the Study of Liver Disease recommended high volume therapeutic plasma exchange level 1, grade 1 evidences acute liver failure, but they didn't make any recommendations for the acute and chronic liver failure. In 2011, American Association for the Study of Liver Disease guidelines suggested plasma exchange as a mean to acutely lower serum copper and limit copper-mediated kidney damage in Wilsonian acute liver failure while awaiting transplant. However, they have not made any recommendations for general use of therapeutic plasma exchange, acute liver failure, and acute and chronic liver failure patients. So now coming to bioartificial liver, where these uses cells. So first I would like to discuss bioartificial liver or hepat assist. So Aribos first described ball devices. So they work on the concept of combining hepatocyte bioreactor with a column filled with cultured hepatocytes to mimic liver function. In hepat assist, so the patient's blood is initially separated into plasma and cellular components. So the plasma is then passed through high flow plasma circulation loop and then through a charcoal filter, oxygenator, heater, and hollow fibers bioreactor containing 7 billion cryopreserved hepatocytes. So once after passing through this bioreactor, the plasma then combines again with the cellular component and is sent back to the patient's blood. So there is a plasma separator where the plasma is treated with hepatocyte seeded bioreactor where the albumin toxins and all the other toxins are removed here, and the plasma is mixed with the patient blood and it is again given to the patient back. So there are no clear-cut studies or guidelines for use of this. So there are only phase 1 studies phase 1, phase 2, phase 3 clinical trials. So Watanabe, studied around 31 patients in phase 1 with the goal of developing a ball for patients with severe liver failure until they can be transplanted or recover spontaneously. So in group 1, 16 out of 18. So patients were successfully bridged to liver transplant. In group 2 patients, there were 3, all they were bridged successfully to the transplant. In group 3, so out of 10 patients, 8 patients expired as they were not candidate for the liver transplant. Phase 2, phase 3 clinical trials from multiple centers across US and European studies involved 171 patients. So the inclusion criteria in these like hepatic grade 3, grade 4 encephalopathy with primary non-function of transplanted liver. So these groups were randomized receiving standard of care and daily treatment with hepatitis for 7 hours. So results for the trials were inconclusive and failed to show an improvement in 30-day survival rates. So all the good safety profile was noted. And subgroup analysis indicated that hepatitis session might provide an improvement in survival rates in patients with drug and chemical toxicity-induced liver failure. So coming to the ALOT, so extracorporeal liver assist device. So this modality was first developed by Sussman et al. So ALOT consists of hepatoblastoma C3S cell line. They are derived from the human hepatoblastoma cell line from HepG2. So these cells are localized in extracapillary spaces of modified dialysis. So cartridges to prevent removal of immunoglobulin bed cells and C3 tumorigenic cells from crossing over. So in this, the system is an investigational use to support the patient. So there are 2 main fluid recirculation circuits. So the whole blood circuit connected directly to the patient and the ultrafiltrated plasma circuit containing the 4 active human 3CA self-filled ALOT bioreactor cartridges. So once plasma is treated here, it is again given back to the patients. So a pilot study was done by Ellis et al. In King's College. So in patients with acute liver failure who were judged to have greater than 50% survival, and in those who were already indicated for liver transplant. So in these 24 patients were randomly divided into 2 groups, allowed hemoperfusion versus control. The overall survival in allowed hemoperfusion was around 78%, like 7 out of 9, and survival in controls were almost similar, 75%, 6 out of 8. So due to the small sample size, the study failed to show an improvement in the survival rate of patients with acute liver failure. So Millis et al. Studied a modified version of ALOT to determine the safety profile of the devices. So for the patient with permanent hepatic failure. So all these patients successfully had a liver transplant with 4 out of patients surviving the 30-day survival endpoint of the study with no noted biomechanical problems or hemodynamic instability. The authors conclude that ALOT is safe and to be conducted on a large scale in multi-center RCT trials. So I'll end it here. So I think so we'll take questions. Thank you, sir.
Go to the last slide, Vishnu.
So these are all the support devices actually kept in one place actually. So like artificial devices and bioartificial devices. So in artificial devices like a single pass dialysis. So the clinical study showed that equivalent biomedical, biochemical parameters compared with Mars. So possible concerns with citrate anticoagulation. In Mars, so there was improved toxin clearance, improved hemodynamics. So there was no evidence of improved survival in acute or chronic liver failures. In the Prometheus, so there was a limited survival data in acute or chronic liver failure. Therapeutic plasma exchange, there were improved hemodynamics, so clinical and biochemical parameters, and increased transplant-free survivals. So bioartificial devices like Hepatologist, they showed improved clinical biochemical parameters in acute liver failure and primary graft non-function, and there were no survival benefits. In modular extracorporeal liver systems, so it has been successfully used to bridge to transplant. So in academic medical center bioartificial liver, there was improved in biochemical and clinical parameters as a bridging therapy. So in extracorporeal liver assist devices, trials are currently in progress. So, but it is safe in acute and chronic liver failure. So spheroid reserve biofiltrated livers, these are only animal studies. So they showed improved survival and decreased ammonia and decreased ICP. So there were no human studies in this.
Yeah, thank you, Vishnu, for that overview. And it was an extensive presentation. Go to the previous slide, just the previous slide. So, Dharmesh sir, actually, we have a set of intensive care colleagues here, and we have been listening about this liver assisting devices, maybe from the last 2 to 3 decades, and they've been used in a smaller, few centers across the world, including you being one of the part when initially in the your liver transplant unit you used Mars. In general, question is what was the challenge in actually getting a liver assisting devices like a dialysis? We wanted to understand that gap in assisting a liver.
Right. So thank you so much for that question, because I think that is something which has intrigued the ICU physicians over a long period of time. Now, the first and foremost thing that one must say, and you are all critical care guys who've tuned into this program, that any open labeled intervention always tends to overestimate the benefit. And doing randomized controlled trials which are blinded in the ICU is virtually impossible. So just to give an example, supposing there was a way in which you could get a machine which looks like the Mars, and you would say that, yes, I have randomized my patients between Mars with its actual Mars flux cartridges as well as the anion exchanger and the resin, and there is a similar looking machine which is just the standard medical treatment. Within 6 hours, one would be able to tell which machine is Mars, because the standard medical treatment cannot remove the bilirubin. So we know that when you have patients with liver failure with hyperbilirubinemia, much of this bilirubin is bound to albumin. The basic principle of this device is to cause a movement of this albumin bound bilirubin from the patient's blood side to the dialysate side. So to do a blinded study is extremely difficult, and all open-ended treatments always tend to overestimate. So we were the first ones to do the randomized control trial of Mars at University College London in the year 2000-2001. And we were so excited when we found that on the dialysate side, the TNF alpha concentration was much higher. But at that time, we were very naive in believing that TNF alpha is only an inflammatory cytokine, pro-inflammatory cytokine. We also must remember that it is the first trigger for liver regeneration. Ditto for what Dr. Vishnu mentioned with respect to hepatocyte growth factor. So, all these things we have been talking about since decades, but it's still not known as to what works at what stage of the disease. So my take on this is that the immune pathways in human beings are redundant. So it's very difficult to categorize a patient at a given stage of presentation, whether he's predominantly pro-inflammatory or he's gone to the stage of the anti-inflammatory response syndrome. And using any of these devices at the latter stage is fraught with danger. So that is why none of these devices has shown any mortality benefit. Of course, it will show that bilirubin has come down. It's a no-brainer, because bilirubin is bound to albumin, and albumin is something that is very high on the dialysate side. You've got 600 mils of 20% albumin on the dialysate side. The concentration of albumin on the patient side is measly, between 2.5. And because albumin is a shuttle moiety, so this particular molecule, it binds to the outside of the Mars flux membrane. And that is why the bilirubin gets shifted from the patient side to the dialysate side. And then you try to regenerate the albumin on the dialysate side by sequential passage over the activated charcoal and the anion exchanger resin. So that is something to remember. So for the PGs in training, there are only 3 randomized controlled trials with these devices. The acute liver failure trial is called the full Mars trial, FULMARS. This was a multicentric trial which was done in France. Fauji Saliba was the principal investigator. The problem with this trial was that most of the patients actually got a transplant within 24 hours of being enrolled into the study. And there were some patients who did not receive even a single Mars session. But let us look at this study critically. So those who were treated with Mars, actually they had new onset of bacterial infection as well as fungal infection. So the invasive fungal infection with any of these devices is extraordinarily high, and hence that tempers your usage of these devices. So as Dr. Vishnu showed that even in the Finn-Larsen study of high volume total plasma exchange, which is about 8 to 9 liters, just the inventory in the blood bank will go dry if you think about doing this study in our part of the world. So most of the studies in the Indian subcontinent and in other parts where TPE has been used have been with 1.5 to 2 liters of plasma. Now let us look at this study. So if you read this paper, it tells you that probably these patients were not enrolled consecutively. So 10 years is too long a period of time to enroll 150 odd patients. And second, these are very high volume centers which have participated in these studies. This study was published in a number of small anecdotal studies prior to the main publication, wherein they use the standard volume plasma exchange, which is about 1.5 to 2 liters. Just for the those who are uninitiated, when we are talking of the plasma exchange, roughly the plasma volume is 40 to 60 mils per kg. This is relevant for patients with acute liver failure. Acute on chronic liver failure patients will have NSRK, and therefore you have to go back to another formula, which is called the Nadler's formula. So those of who use this therapy would be aware of this. So if you are removing 8 liters of plasma on 3 consecutive days, that is a huge ask. But in this study, the best survival was with patients who went upfront for transplant. So it was not for those patients in whom total plasma exchange was used as a bridge to transplant, but the best survival was in those patients who received upfront transplant. So what does this tell us? This tells us that if you have a patient who's critically ill, who fulfills the criteria for transplant, at least on our unit, we would want any of these bridging therapies to be used very sparingly, unless there is a compelling reason to use that. The good part of the study is that there was a small cohort of patients who actually were not candidates for transplant. Their therapeutic plasma exchange and total plasma exchange in this cohort showed a slight survival advantage over standard medical treatment. So that means for me, this therapy at best is rescue therapy. So it is not something that I can offer to all comers. This is not something that is very easily doable. We all must understand that those of us who work in the critical care unit, acute liver failure patient with citrate anticoagulation, it's an enormous drain on the resources, and it's not easy. Second thing is that what he's not shown in the fine print is that these patients actually did have more pulmonary complications in the plasma exchange group vis-a-vis the SMT group, which is quite intuitive because we are putting in huge amount of plasma into patients who already have leaky capillaries. Many of these patients have got acute lung injury. So therefore, it is very difficult to justify this in someone who's already a candidate for transplant. As a rescue therapy, when you've ruled out transplant in a given patient, one might still want to use, though I must say at the expense of repeating myself, that trials with smaller volumes of plasma have not been very useful. The other two studies which he spoke about, one was called the Mars Relief Trial, which was in acute on chronic liver failure, and then the Prometheus trial, which was called the Helios trial. In both these two trials, there was an improvement in biochemistry, there was an improvement in the encephalopathy grade, but that was not sustained, and there was no survival advantage. In the post hoc analysis, in the Helios trial, they showed that patients who had a MELD score of more than 30 and presented with acute kidney injury, they probably did slightly better than the standard medical treatment. But it also remains a fact, and a very important fact for a resource-constrained country like ours, that you should put your best foot forward. If there is a patient whom you have been able to optimize for transplant, that is the first treatment I would want to offer to this patient, and not, get carried away by a bridging therapy. Then coming to the CMC paper, where Dr. Vishnu described the use of low volume plasma exchange, which is about 1.5 liters or so, along with steroids. So he very elegantly mentioned that you cannot attribute the benefit to corticosteroid vis-a-vis the plasma exchange. But if you look at the 1 year survival, it is no different. So you want your patients to survive through not just the ICU, stay, but the hospital stay and also go out into the community and not come back. So please remember that the acute on chronic liver failure patients, they are a huge drain on resources. And these patients, they keep coming back to the hospital with another episode of decompensation. They might get second infections. And typically these patients remain high acuity. So high acuity patients in the context of liver disease are defined as those who've got a MELD of more than 25. And just to keep these patients stable, it actually burns a huge hole into the pocket. And that money could be better utilized by offering these patients liver transplant at the right moment. So I think if you have to put everything in perspective, the verdict on whether plasma exchange works or not is still not known. I'm very surprised that the American Society for Apheresis, just based on the Finn Larson study, actually gave a strength of recommendation 1A. But mind you, it is only to high volume plasma exchange and in the context of acute liver failure. So please remember that more than 85% of this patient cohort was a hyperacute liver failure. Hyperacute liver failure in the Western world is acetaminophen, which we hardly ever see in our country. Most of our patients would present either with acute liver failure or subacute liver failure. And like I mentioned right at the beginning, those probably might not be the best candidates because they have been unwell for a fair length of time. And this pro-inflammatory, anti-inflammatory sequence might not be very well interpreted in this cohort of patients. So I think we still need to treat these patients with good intensive care, take care of the things that you ordinarily do. So protect the airway, hemodynamics, nutrition, cerebral function, clotting, and then in a given patient who's a good candidate for liver transplantation, to be able to list these patients at the right moment so that you will get a good outcome from liver transplant in these patients. So that is how I would want to summarize this entire talk. Please remember that in apheresis, there are various categories, and acute liver failure actually it gate crashed. So by being a category 1 indication for apheresis. So there are very well established categories. For example, patients with TTP, patients with good pasture syndrome, patients with myasthenic crisis, so on and so forth. So there are 4 categories. And to my mind, plasma exchange in the way it is done in our country still is a rescue therapy and nothing more than that. Just look at CMC, it's a premier institution. So out of 250 patients who were screened, ultimately you could enroll only 50 patients. And those of you who are interested in this literature, it will always inclusion criteria rule out patients with sepsis. That is something which I have not been very capable of doing even in the last 20 years plus of practice. So how to tell a patient of liver disease or liver failure does not have sepsis is a very, very difficult task.
Sir, you summarized the whole talk in this last 5-10 minutes. So there were some questions which we'll take, sir.
Yeah, please go ahead.
Bioartificial devices in India are available anywhere, and any experience with you, the centers which do it?
So the question is whether the bioartificial devices are available. The answer is no. So we have the CERSI device, which is the BAL device, and the ELAD, which is like, it's no longer available. So it uses the human hepatoblastoma. This was the Sussman device. There is a fear that you might have a kind of an oncogenic potential being transmitted to the patient. And with those devices which use the porcine hepatocytes, there is a distinct risk of the porcine viruses gaining entry into the host. Now we have gone on to the next stage, which is the organoids and 3D printing. So I think probably we might end up writing an obituary for the biological assist devices. So I don't think any one of them is going to see the light of the day.
Is there any center who is doing high volume plex in India?
No, not in our country. So most of the centers and whatever published experience is there, and there is published experience from PGI Chandigarh, from All India Institute, from Institute of Liver and Biliary Sciences, all very, very contradictory. Some say that early survival benefit is there. Some say that medium-term survival benefit is there. But all of them are unanimous in one particular conclusion, which is that long-term benefit, which is something that we talk about at 180 days and 360 days does not exist.
So you spoke about very interesting part, like in the whole phase of the liver failure, like septic whether we are in pro-inflammatory phase, anti-inflammatory phase, compensatory phase. The million-dollar question is to know in which phase we are.
And we can't. So that is the conundrum. So that is why I think the situations in which these devices have shown some survival benefit might be when the patient has presented really early to a given center and the therapy has been instituted very promptly. Just slightly digressing from this point, there is a very common cause of toxin-mediated acute liver failure in the southern part of our country, which is with yellow phosphorus, rat oil poisoning.
Yes,
And
yes.
there is experience from Kerala as well as Tamil Nadu, wherein they have used the therapeutic plasma exchange to good benefit in this cohort of patients. But this has only been in those situations where the patients have presented early to the centers.
Sir, any experience in the paraquat being one of the toxins which we see more frequently?
Yeah, so we have not used plasma exchange at our center in this particular device, but you know that many of these patients, rather most of these patients would need some kind of a renal replacement therapy during the course of their illness. Once it presents with the hemodynamic changes and also shocked liver, which most of our patients do, by the time they present to us, the mortality is extraordinarily high, regardless of what you do for these patients.
True. Sir, we are now also seeing some viral acute liver failures, including dengue being a phenomenon in 2020, where we're seeing some acute, in fact, hyperacute fulminant liver failures. So what is your take on that, sir? It's been a almost 100% mortality in many of those contexts.
Yeah, so anecdotally, we have used, I still remember from on my fingertips, the survivors from this, but I do not know whether it was a sheer coincidence or whether the therapy, and I'm talking now for Mars, whether that was the liver assist device that worked. But anyhow, so like I said, for us in the current scenario, it is just a continuous veno-venous hemofiltration or hemodiafiltration. So we just swear by that. And our unit is no longer using any of the liver assist devices.
So you mean to say when a patient with acute hepatic failure with maybe some hepatic encephalopathy, raised ICP, the CRRT with veno hemodiafiltration may be a phenomenon to clear
Yes.
ammonia and bilirubin and may be beneficial in rising in ICP case.
Yeah, so bilirubin, no, because you know that membrane is not cut out to remove bilirubin. So in hemofiltration, so basically the indications for hemofiltration in acute liver failure are mostly non-renal. So there will be somebody who's hyperammonemic. So an arterial ammonia of more than 150 micmoles is an indication. Someone who has got clinical features of increased ICP is an indication. Hyperlactatemia is an indication. Hyperkalemia is an indication, and temperature control. So that is something which we never talk about. So, you know, a febrile acute liver failure patient is like a ticking bomb, and there is no better treatment than an extracorporeal treatment to control the temperature in a patient like this. So in our country, we don't actually use the therapeutic hypothermia as a modality of treatment. And but this serves very well partly that particular function. So these would be the indications in a patient with acute liver failure. In acute on chronic liver failure, it's more to provide the renal support to these patients. So while we are preparing for a transplant in a patient who otherwise fulfills the criteria, say for acute kidney injury or an HRS1 presenting as one of the organ failures in the context of acute on chronic liver failure, we would be using hemodiafiltration. For ALF, just hemofiltration is good enough. You know, there is hardly any solute load.
So one point around pregnancy related acute liver failures, AFLPs, and we see sometimes the acute liver failures in the pregnancy. In that context, the role of these devices and your position.
So I think the pregnancy related acute liver failures are the ones in which you know that the most important aspect of treatment is to deliver the baby. And then you should be managing these patients like any other liver failure patient. So your treatment should essentially hinge on good liver intensive care for these patients. We should also be mindful of the fact that at times, at least about 20% of these cases can present after delivery also. And therefore, you would be well within your rights to use every tool that you would in a patient with acute liver failure presenting in a non-pregnant state to your liver unit. So like I said, at the expense of repeating myself, we don't use the liver assist devices any longer. Actually, I'm not even sure whether what the therapeutic plasma exchange is doing is something that you would be able to achieve just by a high cutoff membrane. So that is something probably that we need to pick the brains of on our renal colleagues. What is their opinion on that?
Sir, any differences you find with the plasma exchange, which is done with the renal colleagues, and also one that was done by the blood bank colleagues during this high bilirubin states in some of the contexts?
Right, that's a wonderful question. Actually, I don't know how I forgot to highlight this. So this is extremely important. So the membrane-based plasma exchange versus the centrifugation-based plasma exchange. Most centers use the centrifugation-based plasma exchange. Now, in liver failure patients, this makes even more sense because you know that in the centrifugation-based plasma exchange, the blood flows are lower. And also because the blood flow is lower, you can exchange more plasma. Whereas in a membrane-based plasma exchange, you would be able to exchange only about 30% or so of plasma. That is called the plasma removal efficiency of the device. Whereas in the centrifugation-based plasma exchange, you can remove about 60 to 65% of the plasma. So the PRE is much higher for the centrifugation-based plasma exchange than the membrane-bound. In the membrane-based plasma exchange, the blood flows are much higher. Many of the times these patients have got saggy hemodynamics, and therefore even when these patients are on either SLED or hemofiltration or on a plasma exchange, you always start off with much lower blood flows so that the hemodynamics are not compromised. So in our center, whenever we have used therapeutic plasma exchange, it's almost always been a centrifugation-based plasma exchange.
Okay. So that actually winds up many of the questions. You highlighted one point that many of these assisting devices were bridging therapies, and they finally led to either a transplant will be the standard of care in many acute liver failures where there is an absolute indication. And you said the situations where the transplant, they are not a candidate for transplant. And is that been many times a situation where there is affordability is a question, availability is also a question? Is this all options can be an option there?
So that's exactly what I was trying to say, that if I am given the choice and told that this particular patient is a case for transplant, my threshold for using any of these bridging devices will be extraordinarily high, because what you do not want is to have put in a new organ and then battle infections. So there is a common thread which runs through the use of all these devices, and which is an increased predilection to develop new infections. And that is my biggest fear.
There were questions related to what about few bilirubin filters available right now for ACLF and ALF?
Bilirubin filters. I'm not aware of that. I'm sorry. I'll probably need to read that up.
There have been some Chinese production where they were actually claiming to have a bilirubin filters with that.
So there is a study that I know of, which was done, quite a few years ago, where they have used a generic term, which is an ALS, and they showed that in patients who have got hepatitis B virus-related flares leading to acute and chronic liver failure, if you used ALS and you were able to lower the MELD score of these patients, then these patients did much better after transplant. But that is just a one-off study. I'm not really aware of something being just being a bilirubin filter. Not aware of that.
Yeah, the Jaffra and some companies. So yes, again, we don't have any strong evidence in support of it. So it's been anecdotal reports here and there.
Right.
So thank you so much being with us and actually enlightening all and probably crisply actually summarizing the whole things in such a short time, sir. Thank you for being with us. It's an honor and pleasure to have you on board, sir. Thank you.
My pleasure. Thank you so much. And thanks to all the folks who could tune in for this excellent presentation by Dr. Vishnu.
Thank you, Vishnu, for your excellent presentation. And we thank all the participants and conclude the session. Thank you all.
Thank you.
Thank you. Thank you. Good night. Cheers. Bye.